Welcome to part 5, which is going to focus on nutrition. Nutrition is a very important topic for all of nursing. It's also a review of anatomy and physiology, so if you need more review, go ahead and read your book chapter related to nutrition or review your anatomy and physiology. So many issues and diseases can be caused by our diet, and so many things can be improved by changes in our diet. For the purpose of Block 1, this PowerPoint is going to focus on nutritional basics. Any disease process we discuss in Block 1 that has a nutritional component, like diabetes, will be discussed with that disease. Nutrition is the process by which the body metabolizes and utilizes food. Every body system is affected by nutrition, so it's really important for nurses to understand how the body digests and absorbs nutrients, how important it is that we meet our daily nutritional requirements, how nutritional imbalances occur, and how to assess for imbalances. We already talked about how the body digests food, so let's look at how the body metabolizes it. Metabolism is the biochemical reaction within the cells of the body. For these reactions to occur, the cells need energy, and that energy comes from our food. The body needs a certain amount of energy to function, either function in its resting state, which we call basal metabolism, or to function in a high energy state like while we're exercising. The basal metabolic rate, or BMR, is the bare minimum amount of energy in kilocalories, which we usually just call calories, that the body needs just to maintain life. It's not building any muscle, it's not breaking down any fat, it's just maintaining life. BMR differs for men and women due to the differences in muscle mass and fat mass and hormones. Other factors can affect our BMR, like infection, fevers, extreme temperatures, stress, medications, alcohol, and even our age. In addition to BMR, we look at a person's total daily energy expenditure, which is all of the calories used to perform physical activity, maintain metabolism, to digest, absorb, and metabolize our food. We also look at a person's total daily energy intake, which is the total amount of calories for each food item eaten in a day. We can take the total daily energy expenditure and their total daily intake differences to determine if their weight is stable, if they could be losing weight, or if they could be gaining weight. To maintain a stable weight, the difference needs to be 0. The amount of calories eaten is the same as the amount of calories burned. To lose weight, the amount of calories burned needs to be more than the amount of calories eaten. And to gain weight, the amount of calories eaten needs to be higher than the amount they burned. Body mass index, or BMI, is a way to determine if a person is well nourished and that the weight is appropriately distributed for their height. BMI is measured in meters squared and serves as a number on a chart to help providers determine if the person is healthy weight-wise. BMI can be used as an estimation for risks for disease that occur more often with increased body fat, like heart disease, hypertension, diabetes, and certain cancers. However, BMI is not perfect. It can be inaccurate for people because it doesn't take into account their muscle mass versus fat mass. Athletes who usually have a low body fat percentage and high muscle mass can oftentimes be considered overweight or obese if we're looking at the BMI alone, because it's only looking at the height and weight, and it's not taking into account that muscle weighs more than fat. Because BMI is not perfect, it's also important for us to look at a person's fat distribution when assessing them for nutritional issues. This is because the location of where a person is carrying most of their fat can affect their health. A person with fat equally distributed all over their body is at lesser risk for certain diseases like heart disease and diabetes than someone who has the majority of their fat centrally, meaning around their abdomen. There are 6 specific biochemical substances used by the body for growth, development, activity, reproduction, lactation, health maintenance, and recovery from illness or injury. The 3 that supply energy to the body, meaning they provide calories, are carbohydrates, proteins, and fats. The other 3 nutrients do not supply calories for energy, but they regulate body processes. These are vitamins, minerals, and water. Without all 6 of these nutrients, the body cannot function properly. Different stages of life have different nutrient needs. Young and middle-aged adults need less and less nutrients over the years. The amount of energy burned decreases, so they don't need to eat as many calories as they once did. This means that without a caloric intake change, obesity can become a problem. Women on birth control pills need extra vitamins like iron and calcium, and those who are pregnant and breastfeeding require more protein, calcium, folic acid, and vitamins. Adults over the age of 65 have a decreased need for energy as their metabolic rate slows, but they still require vitamins and minerals. The older adult has decreased saliva, decreased thirst sensation, decreased peristalsis, and they can start losing teeth. These changes, along with decreased income, decreased ability to perform their ADLs like cooking and eating, and lack of support systems can cause malnutrition. The first nutrient we have is carbohydrates. Carbohydrates are a major source of energy, providing 4 calories per gram of carbohydrates. This is the most abundant source of calories and the least expensive. Carbohydrates are the sugars and the starches in our diet and can be classified as simple or complex. They're more easily and more quickly digested than fat and proteins, and our body uses about 90% of the carbs we take in. Once digested and absorbed, carbs get converted to glucose to be transported around the body. The cells then burn the glucose and use it for energy. It's recommended that an adult receive 45 to 65% of their total calories by complex carbs like whole grains. Simple grains provide calories, but they have little nutritional benefit and should be limited. Next, we have protein. Protein is a vital component of every living cell and is required for the formation, maintenance, and repair of all body tissues. Protein is required for blood clotting, fluid balance, tissue healing, hormones, and so much more. Proteins provide 4 calories per gram, and adults should consume about 10 to 35% of their total calories in protein, or about 0.8 grams per kilogram of body weight. Proteins can be complete or incomplete. Complete proteins contain sufficient amino acids, which are the simplest form of protein, to support growth, and incomplete proteins are missing one or more essential amino acids. Animal proteins are complete, and most plant proteins are incomplete except for soy and quinoa, which those are actually complete proteins. Dietary protein is broken down into amino acids by pancreatic enzymes in the small intestine, which are then absorbed and transported to the liver. In the liver, the amino acids are recombined into new proteins, or they're released for use by tissues and cells. We can measure a body's protein level by looking at our blood albumin and prealbumin levels. Both of these levels give us a good idea of the body's nutritional status. These labs are important for you to remember. You're going to hear about them again with skin and wounds and again with fluid and electrolytes. Albumin level is 3.5 to 5 grams per deciliter, and it's a good indicator of long-term nutrition or malnutrition. Prealbumin is 15 to 36 milligrams per deciliter and is a good short-term nutritional status lab value. If a person's prealbumin and albumin levels are normal, then we would say that the patient is well nourished. Next, we have fats. I know dietary fat has a bad reputation, but the essential fatty acids we get from our dietary fat is actually incredibly important for metabolic processes. Unfortunately, most people get their dietary fat from bad fat sources, which is why fat developed their bad reputation. Fat provides 9 calories per gram, and it should be no more than 25 to 35% of our diet, ideally 10%. Dietary fats are comprised of 95% triglycerides, and triglycerides are the major storage form of fat in our body. Fats can be saturated or unsaturated. Saturated fats have more hydrogen than unsaturated fats, and saturated fats will raise cholesterol levels, and unsaturated fats will lower cholesterol levels. So it's better for us to have more unsaturated fats in our diet. There are also trans fats that raise bad cholesterol levels and lower good cholesterol levels. Eating too much saturated and trans fat can increase the risk of heart disease, stroke, and diabetes. Fat digestion occurs largely in the small intestine. Bile, which is secreted by the liver and stored in the gallbladder, emulsifies the fat so the pancreatic enzymes can break it down for digestion. Fats are then absorbed into the lymphatic circulation and then transported to the liver. Next, we're going to move to our non-energy providing nutrients, and the first one's going to be vitamins. Vitamins are organic substances that are present in small amounts in foods. Vitamins are essential for normal metabolism, and they're used as catalysts in biochemical reactions. Fresh fruits, fresh vegetables, they're usually higher in vitamins than processed food because the actual processing of the food is going to destroy most vitamins. Vitamins can either be fat soluble or water soluble. This just determines where they get absorbed. Water soluble vitamins like vitamin C and vitamin B complex are absorbed through the intestinal lining, but they're not stored by the body. We have to get them provided daily in our food. Fat-soluble vitamins like vitamin A, D, E, and K get absorbed with fat into the lymphatic system. The body can store these vitamins in our body, so if somebody were to take too much of these types of vitamins, they can develop toxic levels. And then vitamins A, C, and E, and beta carotene are antioxidants, and they can actually reduce the risk of certain cancers. Those kind of vitamins are found in fresh foods, or you can take them in a high-quality supplement. Minerals are inorganic elements found in body fluids and tissues, or they can be combined with organic compounds. Some minerals function to provide structure in the body, while others help regulate body processes like fluid balance, acid-base balance, nerve cell conduction, muscle contraction, and hormonal activity. Minerals are not broken down by the body, but they're found in what remains after digestion has occurred. Major minerals are ones that are present in the body at greater than 5 grams, and they include sodium, chloride, potassium, calcium, and magnesium. These minerals are what we call electrolytes, and you're going to learn more about them with your fluid and electrolyte lecture. Trace minerals are those present in the body at less than 5 grams, and they include selenium, manganese, zinc, iron, etc. We don't focus on these minerals as much in nursing unless our patient is severely malnourished, and usually that's when a registered dietitian is getting involved in the care. The last nutrient we have is water, and water is a critical component of the body, and it's present in every cell. It comprises 50% to 60% of an adult's total body weight, and humans cannot live more than a few days without water. 2/3 of our water is stored within the cells, and the remainder is stored extracellular. Extracellular is going to be body fluids like plasma and interstitial fluid. Water provides the medium necessary for all chemical reactions to occur in the body, so it's needed more than food is. Water is found in our beverages and in our solid foods. And water affects our fluid balance, and it can easily be too little in the body, which we would call dehydration, or too much, which we would call fluid overload or fluid excess. Most of the time, nurses are caring for patients that are sick, which means they may or not be eating well or maybe haven't been eating well. So it's important that we conduct a nutritional assessment upon admission and as needed to screen for any nutritional issues. In addition to height and weight to calculate their BMI, we should be looking at their fat distribution, and at a minimum, every person should be asked about any changes in weight over the last month and also in the last 6 to 12 months. We need to look at their appetite or dietary habits to see if they've changed and to see if they've been having any difficulty feeding themselves, eating, chewing, or swallowing. We also need to ask if they have a history of abnormal labs or health conditions such as cancer, COPD, HIV, heart disease, hypertension, and diabetes. Other questions we can ask if needed include, has the patient had any nausea, vomiting, or diarrhea lately? What are their food likes and dislikes? How do they prepare and store their food? Do they eat alone, with their family, or in a group? Do they take any vitamins or supplements? Do they follow any particular diet? Do they have any especially strong cravings? Are they following any weight loss plan? And if they are, who's managing it? If we really need a detailed idea of what the person eats in a day, we can ask them to do a 24-hour diet recall, which would include the time the food was eaten, the amount of food that was eaten, the method the food was prepared, and where they ate. If we need more, we can do this for 3 or 5 days. In the healthcare setting, it's pretty easy for us to know all of this information because we're supplying their meals, but that doesn't let us know what they normally eat. It's just letting us know what we've been providing. So sometimes we do need more in-depth diet information. There are many serum or blood lab studies we can do to see the nutritional status of our patients. Hemoglobin and hematocrit are related to iron and protein levels and fluid volume. Albumin and prealbumin are related to protein. The BUN tells us how well the kidneys are filtering out waste products of protein metabolism and our fluid volume status. Glucose levels tell us if the patient has too much or too little sugar or glucose in their blood. Cholesterol levels tell us how much fat a person has in their diet and how well the body is storing and processing it. And iron levels tell us how much iron from their protein sources a patient has. Intake and output is a great way to make sure everything the patient is taking in is going out, either through the kidneys or through the bowels. However, I&O is only as accurate as the person doing it. It's easy to mismeasure urine, forget to chart it, not measure diarrhea or emesis, which is vomit, in milliliters, and we can't count the insensible fluid loss from breathing and diaphoresis, which is called sweating. For accurate I's and O's, every milliliter the patient receives from oral fluids, IV fluids, enteral fluids must be counted and documented. Every ml that leaves the body needs to be counted. Every ml of urine, every ml of liquid bowel movements and emesis, or at least documenting the number of formed solid bowel movements the person's having. When we get this strict on I&O, we call it strict I's and O's, and we do this for patients in the ICU, patients with heart failure, and patients with kidney issues. People should normally take in 6 to 8 glasses of water a day. Some patients may be on a fluid restriction, which means the provider orders the patient not to have as much fluid, and fluid restrictions don't just include oral fluid, they include IV fluid as well. So sometimes we have to be very careful with monitoring intake on people with fluid restrictions. The output of people, especially urine output, should equal what they took in from IV and oral sources. When intake and output are equal, the kidneys and bowels are filtering out exactly what they're supposed to. Sometimes we give medications to make people pee out more fluid than they take in, and sometimes we give people a lot of fluids, even more than they can pee out. We already mentioned that weighing people and using BMI, but did you know that weight is an awesome indicator of fluid volume status? It's actually the single most important indicator of fluid status, as weight can change rapidly with fluid intake or fluid output. Some diseases that we're going to discuss in Block 1 require daily weights because the fluid status can change so rapidly. When we do weigh a person, it should be first thing in the morning after they went to the bathroom with the same clothes on the day before. It's really easy to do when the patients are wearing a gown. If they're bedbound, we need to have the same amount of linens and pillows in the bed as the day before. And I mean, we need to take off as many as humanly possible. We don't want to weigh these people with 3 blankets and 2 pillows. If they can get away with 1 blanket and a sheet while we weigh them, that's all we should be putting on there. Some health conditions require that a patient be on a specialized diet. And I mean a diet where we're giving specialized food, not a diet where we're trying to get them to lose weight. There are many types of specialized diets, and then each type of diet can have its own variations depending on the person's nutritional needs. The most common type of diet is a regular or general diet. This is what anyone who doesn't have a disease process that requires a special diet is going to have. Next, we have a diabetic diet, which is also called an ADA diet or a consistent carbs diet. These diets are for diabetics who need a specific balance of carbs, fats, and proteins with less simple sugars. We can have a low sodium diet where the provider actually specifies how many grams of sodium a day the person can have. We can have low cholesterol diets for patients with cardiac issues. We can have renal diets for patients with kidney disease. These would usually incorporate some sort of fluid restriction and can possibly have low potassium or low protein as well. We can have high fiber diets. We can have soft, low residual diets. We can have pureed and mechanical soft diets for people who have issues chewing or swallowing. We can have clear liquid diets or full liquid diets for patients who can't have solid food. So you can see that there are a lot of different diets we can have, and there's probably even more that I don't even have listed. There's just a lot out there for everyone. When we do interventions for patients with nutritional needs, a lot of it's going to be based off what the provider orders, or it's going to be with the help of a registered dietitian. If your patient has nutritional needs, you should try to get an order to consult the registered dietitian, as they're going to look at all the nutrition all day long and really spend a lot of time with the patients, helping them get the best nutritious meals they can. Our interventions really need to be individualized for the person, because we all have food preferences and choices, and if we involve the person, we have a better chance of getting them to eat what we need them to eat. If our patient has nutritional issues due to swallowing or eating difficulties, we can get an order to consult a speech therapist or maybe even a occupational therapist who can help with the mechanics of eating and swallowing, or even helping them to physically get the food to their mouth. We may have to do a lot of nutritional education, especially if the diet change is related to a new disease process like diabetes. We also need to continue to evaluate the person's nutritional status, which could be lab values, weights, eyes and nose, physical assessment. And some of our physical assessment could include their appetite levels, any GI system issues they're having, like nausea, vomiting, diarrhea, constipation, abdominal pain, and distension. This is the end of Part 5, Nutrition.